Hello, ladies and gentlemen, dear colleagues. I'm now going to give you an update on diabetes guidelines and focusing on LADA or latent autoimmune diabetes in adults. This is my conflict of interest. Now, very recently, in November, the management of type 1 diabetes in adults was revised by the American Association and the European Association for the Study of Diabetes. And so a number of factors have been considered, in particular, the approach for diagnosis, aims on management, schedule of care, glucose monitoring, there are many novelties here, insulin therapy, hypoglycemia, and so on. Now, in this slide, we give you the evidence for the flowchart for investigation of suspected cases of type 1 diabetes. Now, type 1 diabetes, as we all are aware, is a disease of childhood, but there are also patients diagnosed with type 1 diabetes in adult age. But we need to find out when a patient diagnosed with type 2 diabetes may be a type 1 diabetic patient. But then we do not recognize this patient as a type 1 because the mild hyperglycemia is present. So we follow this patient as a type 2 diabetes. They go into insulin failure and therefore they start insulin. But we never place the right diagnosis. So if we put the right diagnosis at the time we see first this patient, we may have definitely an improvement in our therapy and we protect the beta cell from destruction. So the approach with the subject with suspected type 1 diabetes in adult age, that mainly means a subject that is not frankly obese, but is slightly overweight or normal body weight, is to test for islet cell antibodies. The islet cell antibodies, positive, are definitely type 1 diabetic, and those that are negative, we may have two different approaches according to age, greater than 35 or less than 35. And if are less than 35, you are moving into feature of monogenic diabetes, yes or no. And then you have to test for C-peptide, if yes. And then the C-peptide can decide what to do and how to classify this patient. This is a critical factor that has been introduced, the measurement of C-peptide. Because if this define, for instance, in this case, genetic testing, and you define a monogenic diabetes, when you are here, you have patients that have a different level of C-peptide. And so in this case, type 1 diabetes may be defined if the C-peptide is below 200 picomolar or less than 0.2 nanomolar. If the patient is greater than 35, you can see that these patients, some of these patients may have a low C-peptide between 260 and 600 picomolar liter, that is 0.02 or less than 0.6 nanomolar liter. And if it's low, you have to repeat the C-peptide every 5 years. And if it's greater than 600 picomolar, diagnosis of type 2 diabetes can be placed. Regarding the glycemic targets for most adults with type 1 diabetes, not much to say here, but definitely we need to keep the target pretty tough. And if you look at the new fashionable ways to look at metabolic control, that is the time in range and the timer below range, the now new criteria is to have, with that obtained with continuous glucose monitoring, is to have the time in range above 70%. And the glycated hemoglobin should be less than 7% of less than 53. And then you can see in different conditions, the preprandial, the postprandial. So that is where we stand now. So type 1 diabetic patients should have a glycemic target that is pretty tough to avoid complications. And this is a typical example of a patient that is poorly controlled, as you can see here, with the green that is 46%. And so that is a poorly controlled patient. The advantage of having this system to monitor patients with type 1 diabetes is that you can intervene weekly to avoid to wait 3 months to get the glycated hemoglobin level and decide what type of intervention you should do. So every week you can adjust your insulin therapy or whatever therapy you give into these patients in order to have your target at greater than 70% of TIR, time in range, and very low number of hypoglycemia. Here, the patient at 10% of hypoglycemia. So this has to be kept in mind because it's changing completely our approach to treat patients that are on insulin, not only children, but also adults. As you can see here, this is a schematic for management of new onset type 1 diabetes in an adult. Of course, treatment depends on individualized preferences, capabilities, and circumstances. And what we need to do is to replace insulin as physiologically as possible, avoiding hypo and hyperglycemia, reaching good level of HbA1c and TIR, time in range target, I told you before, greater than 70%. So these are all the glucose monitoring, the insulin therapy, prepare for hyperglycemia and prepare for hypoglycemia. If you go to diabetes care, you can find all these criteria that need to be taken into account when you treat your patient. And I skip because I have more important thing to say there in advance. So indeed, I'm going to move to latent autoimmune diabetes in adults and LADA. So what's the difference between LADA and adult onset type 1 diabetes? I think this is an important concept because LADA was identified in 1993 and is now 30 years that LADA, 29 years that LADA is around, with a lot of publications, and many patients now are diagnosed as LADA. Are they type 1 or type 2? Definitely, they are not classical type 1 in adult age, but they are patients with some features of type 2 diabetes. So this is why it's difficult to place diagnosis of LADA. And I think probably the LADA is unrecognized because most of us do not pay attention to LADA. And if patient is well controlled, we do not investigate for antibodies. And of course, if we do not investigate for antibodies to beta cells, we don't place diagnosis of LADA. So what we have done recently, we have looked at the management of latent autoimmune diabetes in adults, and a group of international experts met and discussed what should be the management of this condition. And among those, there was Tina Tuomineto from Finland, Raffaella Busetti from Italy, Didac Mauricio from Spain, Massimo Paolo from the US, Jijuan Zhu from China, myself, and Richard Leslie from the UK. So in this paper that you can find in Diabetes last year, 1.5 years ago was in October issue of Diabetes, you can look at what we should do when we have a patient where diagnosis is not properly made. So this is the LADA rates worldwide. So as you can see, the number of patients with LADA, there are regions in the world, and in particular, as you can see, the region where you live here is 12 to 15% is the Middle East, is the region where LADA is highly prevalent. Then you can see the Northern Europe, where in particular Finland and Norway, and the data are available, and Sweden, and the UK, Italy, and other parts of the world, and in particular North America and Canada, and you can see the prevalence rate among patients with diabetes. So these are patients with diabetes. And remember that among 100 patients with diabetes, 90% are 80% are type 2, 10% are LADA, can be LADA, and 10% are classical type 1. So LADA may represent a number that total all patients with type 1 diabetes diagnosed in a young age. So it's a remarkable and important form of autoimmune diabetes in adults. So these are the studies where we look at the epidemiology of LADA. This has been reviewed in Nature Endocrinology and the UKPDS, the Botnia study in Finland, in Japan, in USA and Europe. As you can see, there are differences. There are countries where the incidence is lower, and the Northern Europe tend to be higher. And of course, this reflects a higher incidence of type 1 diabetes in this country. And these are the antibodies that have been tested to identify this population. And in a study that was done in United Arab Emirates, in the population of this age, the first study that showed 2.6% of patients that were long-standing patients, and of course, because they were not recently onset diagnosed, the guarded antibody positivity was not so high as expected in patients with recent onset form. So what are the broad characteristics of LADA? These are patients with diabetes. I don't say type 1, with diabetes greater than 30 years. They have a family and personal history of autoimmunity, that have a reduced frequency of metabolic syndrome compared with type 2 diabetes, with a lower OMA index, lower BMI, lower blood pressure, and normal HDL compared with type 2 diabetes. There is no disease-specific difference in cardiovascular outcome between these patients and those with type 2 diabetes. So therefore, that means that these patients tend to develop cardiovascular complications like patients with type 2 diabetes. The C-peptide that could be absolutely relevant to decide what to do and to diagnose this patient decreased more slowly than in the classical type 1 diabetes, but still decreased with the ages. And the positivity for GADA as the most sensitive markers is definitely the key diagnostic test to perform in this patient to make the proper diagnosis. There are also other autoantibodies less frequent, like ICA, insulin, tyrosine antibodies, zinc T8, and tetraspanin 7 autoantibodies. And most important, these patients do not require insulin diagnosis of diabetes. And of course, they may still be in excellent metabolic control for a brief period after diagnosis. None of these features categorically define LADA. There are limited data on older patients with a higher probability of type 1 diabetes in younger patients. Now, how can we define LADA? And what is the algorithm for LADA diagnostic pathway? Now, if you have a patient, and in clinical practice that could happen every day, that is diabetic, with a BMI between 22, 23, and 27, and with poorly controlled diabetes, but with features also linked to autoimmunity history, like other autoimmune diseases in the family, or actually the patient, we may be having autoimmune thyroid disease, you should screen for GAD antibodies. If GAD antibodies are positive, you follow this pathway. If GAD antibodies are negative, but you still suspect LADA, are lean or other autoimmune diseases, screen for IA2 antibody, the tyrosine phosphatase antibodies, because they may be positive in patients that have GAD antibody negativity. If all these are negative, therefore this is a type 2 diabetic patients. Then you have to measure, if the patient is diagnosed with LADA, you have to measure serum plasma C-peptide. And then to measure plasma serum C-peptide, we define 3 different categories of C-peptide. Less than 0.3 nanomolar, that is less than 300 picomolar liter of the previous classification that put 0.2. Here we are between 0.2 and 0.3 nanomolar, less. And this is an important category of patient. Patients that have a C-peptide equal or greater than 0.3 and less than 0.7 nanomolar, and patients that have a C-peptide greater than 0.7. So here, the algorithm defines what we should do. If the patient has less than 0.3 nanomolar liter, definitely this patient needs insulin. May be associated with other drugs in combination, but definitely they need at least basal insulin. If the patient have a C-peptide between 0.3 and 0.7, the LADA algorithm applied. And then I'm going to show you what is this LADA algorithm. If they have the C-peptide greater than 0.7 nanomolar, the classical type 2 diabetes has the guideline applied. So we don't have here to repeat what the guidelines are, because these are the typical guidelines for type 2 diabetic patients, keeping in mind, of course, also the presence or absence of cardiovascular complications. And then the C-peptide should be repeated every 6 months, because if you start with one therapy, that may lead a reduction of C-peptide to go back to this scheme where the LADA algorithm applied with less than 0.3, and so insulin therapy should be initiated. And of course, these patients tend to lose the C-peptide because tend to deteriorate their glucose control, and they may become, by all means, patients that could be treated only with insulin. So now I'm going to show you what to do with patients with C-peptide less than 0.3 or with C-peptide greater than 0.3 and less than 0.7 nanomolar. These are patients that are all LADA because they've been diagnosed with GAD antibodies or tyrosine phosphatase antibodies, where we have measured the C-peptide. So as I said, less than 0.3, no question. Insulin, basal and or prandial, depends how patients do. If they are also insulin resistant, maybe they need other additional therapy. But if the patient have a failure of the beta cells and they tend to have hypoglycemia even after the main meal, despite basal insulin, you should give patients the treatment with other drug or insulin at meals as well. Regarding patient with greater than 0.3 and less than 0.7, use metformin and reassess every 6 months. Do not give sulfonylureas because sulfonylurea speed up the destruction of beta cells. And therefore, by speeding up the destruction of beta cells, you move very rapidly into this category of patients with less than 0.3. Then we have the indicators of high-risk complications and established cardiovascular disease or chronic kidney disease. Now, we have these two populations, and if you have population with the cardiovascular complication that predominates, I think we have option to give GLP-1 receptor agonists that have proven cardiovascular benefit, or also SGLT2 with proven cardiovascular benefit if the eGFR is greater than 27, and consider potential insulin requirement, the risk of future deterioration and ketoacidosis. So you may combine SGLT2 and insulin. And also basal insulin in combination with GLP-1 receptor agonists or SGLT2 in presence of HbA1c greater than 9%. So if despite this treatment, the HbA1c is above target, insulin basal bolus is the only treatment that you should give to these patients. Now, regarding heart failure or chronic kidney disease predominating, SGLT2 with proven CVD benefit could be given if patients have BMI greater than 27 and consider potential insulin requirement, the risk of future deterioration and ketoacidosis. And if the SGLT2 are not tolerated or contraindicated, add GLP-1 receptor agonists with proven cardiovascular benefit. So we have to reach good HbA1c, but if that above target, then you should keep as ADA, ASD guidelines, delete sulfonylurea if these patients were treated with sulfonylurea, because that for these patients should be given only insulin. So I think that looking into this algorithm for glucose-lowering medication, we have learned that the C-peptide represent a key factor in the process of treatment patients with LADA. And in this slide, this is the algorithm for glucose-lowering medications in LADA patients with C-peptide greater than 0.3 and less than 0.7 without established cardiovascular complications. And as you can see here, we have many options. We have the DPP-4, and if HbA1c is above target, we can start basal insulin or GLP-1 receptor agonist or SGLT2. If we have patients that we think that GLP-1 receptor agonists represent the best treatment and the HbA1c is not at target, we can start basal insulin or SGLT2. If HbA1c is above target, then you start with a basal bolus. The same happens in this population of patients without cardiovascular complication. If the SGLT2 are not sufficient to control HbA1c, and HbA1c need to be adjusted, so you can start basal insulin or GLP-1 receptor agonists or DPP-4 inhibitors. And if the patient were on TZDs, then HbA1c with TZDs is not a target, we can then add DPP-4 or GLP-1 receptor agonist or SGLT2 inhibitor. Therefore, we have excellent opportunities here in LADA patients that have no cardiovascular complication or CKD with all different drugs available for treatment. Now, the identification and treatment of LADA definitely poses significant challenges for the physician. And the faculty outlined some key points for future actions that include screening for LADA wherever possible, and in particular when you have patients that are poorly controlled and are not obese. To introduce a personalized therapy, as I mentioned to you before, a need for more randomized controlled comparative trials with different hypoglycemic agents alone or in combinations, further investigation of immune therapy that could actually limit the damage to beta cells, a large-scale long-term studies in different patient population, and in particular in the Middle East country, I think studies of this kind are highly required. Quality of life, lifestyle issues, because patients may start with drugs that not include insulin, and of course patients don't like insulin, and we may continue with other drugs as long as possible as if the metabolic control is reached. So that may affect definitely the quality of life of these patients. Studies including different ethnic groups should be developed and run because we can learn more and more about the prevalence of LADA in different populations. Very significant is the nature of antibodies we're going to measure and the quality of the antibody assay, and not only GADA, but also tyrosine phosphatase and zinc Th should be benefit. And also the cost-benefit balance of measuring GADA and C-peptide, because this could be calculated, but the simple GADA measurement could help in a better definition of patients. And of course, also C-peptide can lead where patients should be treated with the current drugs. So in conclusion, ladies and gentlemen, the ADA and the ASD have recently issued guidance for treatment of type 1 diabetes in the adult age. And so this is a population where we should pay more attention, because these are newly diagnosed in adult age. They are not long-standing type 1. And so far, when you're talking about patients with type 1 diabetes, you always think about the children that develop the disease, and then you follow them. So these are adults. Therefore, this may be not diagnosed, and we need to diagnose these patients. The consensus report has focused predominantly on current and future glycemic management strategies and metabolic emergencies. And all this attitude requires considerable knowledge and skill to navigate between hyper and hypoglycemia, but most important, to place the right diagnosis. So the overall objective of a personalized approach for the management of LADA is to achieve good metabolic control and preserve beta cell function. The guidelines for type 2 diabetes do not suggest any specific treatment for LADA, which constitutes a significant fraction of patients with adult onset diabetes. The panel felt it was important to provide recommendations for the management of LADA in clinical practice, and I hope that the guideline we gave you could be helpful for you to provide the best treatment for these patients. And LADA treatment is defined on the basis of deviation from the other algorithm for type 2 diabetes. So it is not difficult to apply, because you have well in mind what is the ADA ADA algorithm for type 2 diabetes, and then you can apply our algorithm that is driven by the measurement of C-peptide. And the C-peptide evaluates the beta cell function, and based on this, or either low or normal beta cell function, you intervene with the most appropriate therapy. So our overall objective was to provide an easy guideline for personalized therapy for LADA. So LADA is now a relevant form of diabetes that you should always keep in mind when a patient with a doubtful form of diabetes comes to your attention. And even for patients, I suggest to think about LADA when you have other potential autoimmune complications, autoimmune conditions present, and also patients with a BMI that is on the overweight side rather than on the obese side. So these patients, if they are poorly controlled, please keep in mind that the LADA may be behind, and you should place their proper diagnosis to offer the best possible treatment. Thank you very much.